الرحيم. الدكتور أحمد صلاح حميد من قسم جراحة الفم كلية طب الاسنان. محاضرة اليوم راح تكون هي Dental Management of Patient with Pulmonary Tuberculosis. Actually, this is one of the most important lecture. And this disease, particularly pulmonary tuberculosis, it is of importance to the dentist. This is because this disease is one of the transmissible disease, one of the infectious disease actually. It is one of the respiratory disease that can be transmitted by airborne droplets. So it can be transmitted by coughing, sneezing, talking through the airborne droplets. The causative microorganisms of this disease is Mycobacterium tuberculosis. And actually this disease, or this bacteria, I mean Mycobacterium tuberculosis, usually settled in the area of high oxygen tension. For this reason, it is usually infected the lung. For this reason, it is called pulmonary TB. However, sometimes the infection might be spread and involve other organs of the body, such as the skin, vertebrae, particularly the spine, and the lymph node. In this case, it is called extrapulmonary TB. So, other organ of the body could be infected by the Mycobacterium tuberculosis. This disease, if it is not treated promptly, or if resistance of bacteria, Mycobacterium tuberculosis, to certain anti-TB drugs or antibiotics, in this case it will lead to certain complications. And this complication these complications might facilitate the spread of the infection. So the complication of pulmonary TB, if it's not treated promptly, or if the resistance to the antibiotic might be developed, in this case it will lead to cavitary pulmonary TB or cavitary TB, in which there is cavitation. As we can see here, there is cavitation, necrosis to the center, or necrosis of the center of the granulomatous lesion of the TB in the lung, particularly in the apex, usually affecting the apex of the lung. This perforation actually, perforation or this cavitation gives indication that the transmission of disease is more likely. In addition to that, it is more risky, and it increases the mortality and morbidity of the disease. Because through this cavitation, the mycobacterium, through blood supply or hematogenous spread, might spread to other organs of the body, other organs of the respiratory system as well. The other complication is miliary TB, which is involvement of many organs of the body within the infection, within the pulmonary TB. So in this case, it will affect the kidney, liver, pericardium, skin, lymph node, TB, and so on. And actually, this is very dangerous condition, and also it may lead to increase the morbidity or even the death of the patient. So, what are the clinical manifestations of the disease? Usually there is fever, because there is infection, fatigue, weight loss, persistent cough, blood in cough, or what we call hemoptysis, and also there is episodes of night sweating. Actually, persistent cough and blood in cough, this is one of the clinical manifestations of the respiratory disease. But here, the episodes of night sweating might increase the possibility or suspicion of pulmonary tuberculosis. Oral cavity, it is not excluded from the disease process or the infection. So the infection also could affect the oral cavity. So usually you can see there is ulceration in the tongue, particularly in the lateral border of the tongue. Here we have two types of oral ulceration. The oral ulceration could be affected the tongue and also the cheek, the oral mucosa or the mucosa of the cheek from inside as well. Could be primary, could be secondary ulcer. Primary, that means infected directly, I mean the mycobacterium usually infect the tongue. In this case, the ulcer usually painless and associated with lymphadenopathy. Sometimes secondary to the pulmonary TB, spread through the hematogenous route, and in this case, it gives painful ulcer and also there is associated with lymphadenopathy. Actually here also there is diagnostic feature of the ulcer associated with TB, which is undermining. Usually the ulceration, it is characterized by undermining, the border undermining. So this is one of the characteristic features of the TB ulceration in the oral cavity. Also, the infection which involves cervical lymph nodes might give many abscess, and in this case it's what we call collapsed abscess, which is usually one of the infection of the lymph node, and usually the lymph node is not painful but matted or diffused and sometimes separated and so on. So what are how we can diagnose the disease, how we can diagnose patient with pulmonary tuberculosis? Actually this is not the responsibility of the dentist but the responsibility of the physician. This is through physical evaluation, so we can evaluate physically the patient, the body temperature, pulse rate, and so on. If there is persistent clinical manifestation, fever, cough, persistent cough, or hemoptysis, and episodes of NASO for more than 3 weeks, in this case, suspicion of TB is very high. So we have to send the patient for chest X-ray. And in the chest X-ray, as we can see here, there is what we call hilar lymphadenopathy. The hilar lymphadenopathy, could be unilateral, could be bilateral, and this is one of the significant features of the pulmonary TB. Once there is suspicion or the increased suspicion of pulmonary TB from the hilar lymphadenopathy, unilateral or bilateral, we have to send the patient for sputum culture. And the sputum culture here, we have to repeat it 3 times. In addition to that, also we have to do another culture which is for nucleic acid amplification. So this is, in this case, once it gives the results of sputum culture and the other nucleic acid amplification positive result, that means the patient is definitely infected. I mean the establishment of the pulmonary TB. Also, we can use what we call Mantex skin test or tuberculin skin test, and also there is interferon gamma release assays. Actually, both of these assays or both of these tests, this is to support the diagnosis of the pulmonary TB. Here we can see this is actually the tuberculin skin test, in which there is injection subdermally of purified protein derivatives, and actually the result it appears like skin rash, elevated nodules. This can be seen after 2 to 3 days, which also increase the possibility of the infection with pulmonary TB. Now, from a medical point of view, the treatment is by using anti-tuberculosis, and this include isoniazid, rifampicin, and pyrazinamide. Actually, as we can see here, this is combination in order to prevent resistance to Mycobacterium tuberculosis. This can be used for 2 months. Could be isoniazid and rifampicin for 4 months. Also, other drugs could be ethambutol and streptomycin. Actually, streptomycin, it is the first anti-tuberculosis used actually. In case of prophylaxis, to prevent the spread or to prevent the development of pulmonary TB, we can use isoniazid for 6 months to 1 year. Now, from dental point of view, how we can manage patient or dental patient infected with pulmonary TB? How we can manage those patients? In order to manage those patients with pulmonary TB, we can categorize those patients into 4 categories. So first of all, patient with active and positive sputum test. Active, that means the patient develops clinical manifestation, fever, cough, blood in cough, or what we call hemoptysis, episodes of night sweating, fatigability, weight loss, etc. First of all, in order to manage such a patient, consult physician before treatment. Just urgent treatment and by using medication. We have not to interfere surgically or even operatively with those patients. But if dental maneuver is important or urgent, in this case, we can do it in the hospital. Here we have to mention, if the patient years or if the patient age more than 6 years, we can consider this patient more infectious. So in this case, we have to treat such a patient in the hospital, isolated room, sterilization, mask, gloves, and guard. But if the patient less than 6 years, in this case, we can give dental management as normal patient. Why? Because patient less than 6 years, the possibility of expelling the sputum is very low, because usually the patient swallow the sputum, so there is no possibility of transmission of the disease. After having medical treatment for 4 months or for 2 months, we have to consult the patient physician for evaluation, and we can treat the patient as normal. The second category, patient with past history of TB, which is very cautious. Here the approach should be with caution, and we have to obtain good history of the disease process or disease treatment. We have to check whether the patient completes the treatment duration or the full course of the treatment duration, and also there is periodic chest x-ray to see whether there is pillar lymphadenopathy, unilateral or bilateral, and also with physical examination for detection of any relapse, because he has history or she has history of the TB. If patient reveals inadequate medical treatment or not appropriate medical follow-up and sign and symptom of disease, fever, cough, persistent cough or hemoptysis, in this case we have to consult physician and to postpone. Since there is clinical manifestation of TB, we have to consult and postpone. Patient free of clinically active disease, that means there is no sign and symptom, then we can treat the patient or such a patient as normal. Now, patient converts from negative to positive TB tuberculosis skin test. For example, patient may have the suggestion sign and symptom, and we do the tuberculosis skin test and change from negative to positive. That means we have suspicion that the patient might be infected. So in this case, we have to consult his hair physician, and the patient, since there is suspicion that the patient might develop pulmonary TB, we have to give the patient prophylactic isoniazid to prevent the disease for 6 months to 1 year, and then we can give the patient normal dental treatment. So the last category is patient with suggestive signs and symptoms. Patient suggestive, that means there is fever, there is weight loss, there is cough, hemoptysis, episodes of night sweating. In this case, we have to consult physician, because very important to check whether, actually consult physician in order to the other process, the other diagnostic process can be followed. That means to send the patient for sputum culture or nucleic acid amplification, or even to tuberculosis skin test and so on. And then, since there is the clinical manifestation, we have to postpone, and if a treatment is necessary, treat just as above. That means in the hospital, isolation, gown, mask, and so on. So in summary, if we want to summarize the treatment or dental management for patient with pulmonary TB, first of all, after 2 to 3 weeks of treatment, if the patient taking, for example, rifampicin or isoniazid with pyrazinamide, after 2 to 3 weeks, we can give the patient normal dental treatment. If the patient has, or the patient with history of TB, treat normally if no active disease. That means there is no clinical manifestation. Chest x-ray, there is no pillar lymphadenopathy, and no diffusion and so on. And also effusion, sorry. And also positive for patient with positive TB test, that means for patient with positive tuberculosis skin test, in this case, treat normally if no active disease. So if there is no sign or symptom, any patient with history of TB, we can give the treatment normally. If positive tuberculosis skin test, so in this case, we have to give the patient dental treatment normally, providing that there is no active disease, there is no clinical manifestation. In new active TB, treat only urgently and in a hospital isolation room, because new active that been a clinical manifestation, and this is the first time. So in this case, we have to give urgent treatment in the hospital, in isolation, mask, sterilization, and so on. Clinical sign and symptom, or clinical suggestive sign and symptom of TB: fever, cough, hemoptysis. In this case, we have to postpone the patient and do not give the patient any treatment. Finally, actually, vaccination against TB is very important. Pulmonary TB is very important. This is to prevent disease transmission and infection. So this is the end of the lecture, and thank you for your attention.